Okay, I think it's time. It's also to be fair to the ones that were on time. Let's start now. As I said, this is going to be a presentation about the formaldehyde risk. What the risk is it given to all the users, to the nurses and physicians when they are opening the vial, when they work with opening vials. So you can see here the agenda. It's going to be divided in 4 big blocks. The first block is going to be presented by Akran. I will introduce him later, and it's about formaldehyde and in the occupational health and regulatory perspective. Then we will have Professor Hollerbach from Germany, and the title of his presentation is How a Simple Change Improved Safety in Biopsy Handling in his endoscopy department. And then another block will be presented by myself, and it will be about what the closed vial solution can bring as an advantage for you, and a little bit of our history. And then we will have the fourth block, will be Q&A and wrap up. Okay. Another way of approaching this presentation, here we have like some headlines: occupational health, safety, regulation, clinical practice, solutions. Okay, this would be, let's say, a more visual summary of what we are going to do. Please, if you have questions during the presentation, there is a place in your screen when a section called Q&A. Please place them there, and at the end of the presentation, we will answer all of them. Or at least, if there are a lot, we will answer as much as possible. Okay. Then the keynote speakers, as I said, for the formaldehyde exposure is Mr. Akran Salmen Navarro. He's from New York, and he's the chair of the ICO Scientific Committee for Occupational Health for health workers. ICO is the International Committee of Occupational Health. Okay. And Professor Stefan Kollerbach, he's a professor of medicine and gastroenterology and chief physician in the Department of Gastroenterology and Endoscopy at AKH Celle, and adjunct professor of internal medicine at Ruhr University Bochum in Germany. And with nothing else to say so far, I give the word to Akran.
Hello, everyone. Thank you for being here. Thank you for the invitation in such an important topic. I'm going to share my screen so I can start immediately. Okay, just please confirm that that you can see it well and you can hear me well.
Yeah, we can.
Okay, so once again, thank you for inviting me. This is a topic that is of utmost importance for especially for our field. You know, what we do a lot of prevention and in the workplaces. So I'm the chair of the International Commission on Occupational Health, Scientific Committee for Occupational Health for Health Workers. I'm based in New York City, but it's an international organization that basically most of, if not all of the occupational health experts around the world are members of, and we do a lot of scientific interventions and the dissemination of preventive measures. I declare no conflict of interest in this presentations. And first, you know, I want to run a little bit about, you know, what is formaldehyde. You know, formaldehyde is a common colorless, strong-smelling chemical. You know, that is a gas in room temperature. It's a chemical that is, you know, basically everywhere we are. It's in our home. We can find it in plywood. We can find it in glues, in adhesives, permanent press fabrics. In fact, we as humans produce a little bit of formaldehyde as well. Now, it tends to be it tends to be not dangerous in low doses, you know, but you know, when we start using formaldehyde for for industrial or chemical or implementing purposes, then it becomes a more nocive for your health and a bit more dangerous. What is dissolved in water is called formalin. All right, so which is more commonly used in industrial disinfectants and in medicine, in cosmetics, and that's when we try to use the diluting version of it, to be for different purposes. So like I said, it's found in natural in small amounts, even in some foods, including fruits, and we live around it. Nevertheless, we also use formaldehyde for specific reasons, and in this case, we're going to talk about fixing biopsies. Where for routine histologies, around 10% of NBF, which is the equivalent of around 4% of solution formaldehyde. So, regarding this use, there's a purpose for it to be used. There's a purpose for preparation. We do use the buffering, so it can with a specific pH, so it can act the way we want it to act. There's a tissue to fixative ratio also that we use, which is at least 10 times, ideally 15 to 20 times of the volume of the tissue specimen to ensure adequate fixation. And there's a fixation time. I mean, the point of this slide is not to learn how to do it and what, and where to do it and how to create it, but it's to understand that there are specific reasons why formaldehyde is used in fixation, routine histology biopsies, so we can have a good specimen and be used for medical purposes. With that being said, using a concentration significantly higher than 10% of formalin can also cause the outer layer. So there's a specific concentrations that we need. Now, there's health risks when we use clinically in practice. When we have this adequate concentration and fixation part of the formalin, there are acute effects, chronic effects, and unfortunately, it's a carcinogenic effect, more on the chronic side. You have acute effects. We have patients and we have workers where you have eyes, nose, throat irritation when inhaling the fumes or the fumes are in the air. There's coughing, wheezing, shortness of breath, skin irritation, and allergic dermatitis. It's also been described vastly in the literature. Now, unfortunately, there are more serious effects, which are the chronic effects. This can trigger occupational asthma and reduce lung function, especially on patient that has been asthmatic before. That exacerbates the condition. Or you can also have patients who debut with asthma and occupational asthma. So when we talk about occupational asthma, with everything that goes through occupational is work-related asthma that can be caused at work or can be exacerbated at work as a common disease. So many chemicals and many exposures trigger this, and formaldehyde is one of them. There can be a histopathologic changes in the nasal mucosa, and it's also known as a human carcinogen by the International Agency for Research, which I'm going to talk about a bit later. Now, this is like the health risks in clinical practice in general, but there are specific risks when we do clinical fixation workflows. Now, this is what brings us to this presentation, which is there's a pathway through exposure when you are doing the fixation process. Now, these processes change vastly in different health settings, in different labs, in different gastroenterology departments, in different morgues. This is not a standardized pathway, but it's just to give an idea a little bit of what happens. So when you open and handle a specimen jar, when you pour the fixative, when you're decanting in gross rooms, it releases vapor to at the face level or even beyond. There's a transfer step, moving the tissue from one cassette to one container to another, topping the fixative. There's post procedures, which is actually you can have exposures when you're decontaminating the surface. There's managing spill process, that can also expose you to formaldehyde and carcinogenic and health risk levels. There's waste streams. In fact, so we can be exposed in many areas of the actual workflow. And the acute and chronic health effects are the same as the last slide. But in this case, I'm adding the special populations. We have, as we know, 70 to 80% of workers in the healthcare industry around the world are females, are women. And then, we have a lot of pregnant workers working in obviously by their condition as a woman, working in different areas in the health field, and that translates to pregnant workers handling these very dangerous chemicals who are carcinogenic, are pathogenic, and so forth. So these are things that we're very, we're always concerned about, and we're always working towards minimizing the risk as we should. So IARC is the International Agency of Research on Cancer. Every country has their own kind of research agency. Some countries have more robust than others, but this is the international agency, which is the branch of the World Health Organizations, and this is composed by multiple experts around the world, and it's the most respected organization when it comes to cancer, carcinogenic occupational exposures. And they tell you, there's a group 3, group 2B, 2A, and 1. So the lower the number, or the group 1 are well known with sufficient evidence of cancer in humans. And unfortunately, the formaldehyde is a group 1 IR carcinogenic to human. That means that there's it has the highest levels of certainty with sufficient evidence that it's cancerogenic, carcinogenic to humans, as tobacco, smoking, solar irradiation, and so forth. Okay. So, there are many other chemicals that are on group 1, and there are other chemicals that are on group 2A, 2B, and 3, which, are as of now elevating the evidence that, that they might stay on lower groups, or they might go up in groups. In fact, when the evidence wasn't so high, formaldehyde was not on group 1. It was on a lower group. But as of now, the scientific evidence has been high enough to be on the highest risk level. So this is something that it's a fact, it's something that we work with, and we have to also work on prevention. Now, countries have their limits. You have a 8-hour limit exposure, and then you have a short-term ceiling exposure, which is around 15 minutes. So many countries have their different limits on how to be exposed. There are some countries who are more lenient. For example, the regulatory OSHA is lenient towards the exposure in the United States, but NIOSH, who as of now doesn't exist anymore, but when they did all their studies, they were more strict because it was the scientific arm of the occupational health and safety community in the United States. Now the European Union also have their regulatory ceilings on how much you should be exposed before having a serious health concern. And so is Germany, Netherlands, the UK, and so forth. Now, you have the limit of exposures, and experts in industrial hygiene are the ones who measure this and have the expertise and on how to do the interventions, and they work together with us, to prevent all these exposures. But there are also legislative instruments, and key requirements. And the United States has its legislative instrument. Some of them are more strict, more lenient. Some of them are more enforced than others. But we have the tools to work with. So it's very important to understand that, behind these legislative instruments, there has been a lot of work of a lot of experts that put a lot of time into this, to come up with these preventive measures. And Australia has its own legislative instrument. Germany, France, basically most countries have it. And there are key requirements. And the interesting part of the key requirements is that there's always an employer obligation. Because, we have to work together on an employer, worker, and occupational health and safety triad, so we can have an actually participatory implementations to prevent and protect workers. Now, what do we want to do? There's levels of preventions, all these regulatory instruments, all this evidence that has been implemented and revealed, and everything that we are speaking about today brings us to what we do in occupational medicine. Occupational medicine is a preventive discipline within medicine, so we try our best to do primary prevention. Of course, if there's people at risk already with health problems, we have no choice than to do secondary prevention with screenings, at risk of individual, control the risk factors, and early intervention. And sometimes, unfortunately, people are already with health problems. So we try to do tertiary preventions, rehabilitation, preventing complications, and so forth. But our main objective is to do primary preventions and go to the root cause of the problem. And so we want to do health promotion and addressing the risk factor directly to the root cause. So how do we do this? We do prevention through design. So this is a great tool that was developed in NIOSH, and we use it very, very much around the world. So, the best thing you can do is to eliminate. Sometimes we can't eliminate, so we substitute. Sometimes we do engineering controls, we do hazard isolation. And sometimes we do administrative controls, work behavior, rotation, trainings. And sometimes, we do also protective personal equipment. We implement PPEs for workers to wear it. But, the best thing you can do, which is the most effective and the most value for the business and the most value for what we're doing at work on any exposure, and of course with formaldehyde, is to eliminate the hazard. Now, how do you eliminate the hazard? You remove it, or at least you try to minimize the exposure at its maximum. There's always going to be a risk at work. There's no risk-less work. There's always a risk, but you try to work on the minimizing the risk at maximum. And so so with that being said, we try to eliminate, and there's a lot of tools that are being implemented that you can eliminate or minimize the risk at most in different exposures. And formaldehyde is not it's not isolated in this type of prevention through design. So I'll stop sharing for now, and I want of more of the medical and regulatory aspect of it, and and the importance of understanding that there are many chemicals and there are many exposures who are very risky for workers, and formaldehyde is one of them. So this creation of conscious is very important. And I'll stop there, and I'll hand it to Ferran and to the next speaker. Thank you so much.
Thank you. Thank you very much, Akram, for this very revealing presentation. And now we give the word to Professor Hollerbach.
Yes, thank you, Ferran. Thank you, Akram, for this very important talk. I'm very happy to host you all here for this very important seminary. And I would like to ask Annemette to start my talk right now, because I can't do it from here for some technical reasons unknown. All right, so let's start with the first slide, please. So my talk is. So I'm focusing on I'm focusing on the clinical part of formalin exposure in the endoscopy itself locally. So my talk is entitled Healthy Endoscopy: How to Establish a Formalin-Free Environment at Home, if possible. Okay, can I have the first slide, please? All right. So formaldehyde is still considered to be the gold standard for tissue fixation in GI endoscopy for good reason, because it's very cheap and it maintains the shape of proteins and cell organelles, which is very easy which facilitates a great job for the pathologist to look at the tissues. Can you click once more? Scroll down, please. Yes, and we use fixation of biopsy. We have to use fixation agents of biopsies and tissue specimens every day in the endoscopy suite, because we send approximately 30 to 50 forceps biopsy containers to the pathologist each day, and a couple of EMR or ESD specimens per day, which all need to be fixated immediately to make sure the pathologist can obtain a significant diagnosis or relevant diagnosis. However, as you have heard before from Akron, there are several health risks associated with the use of formalin. So let's go through the health risk of formalin use once more. Once you open the formaldehyde containers, you will be immediately exposed to the release of gaseous formaldehyde in your environment. You cannot escape, because it's much lighter than air, and it immediately starts running on your mucosal surfaces. And we can feel it in form of a running nose, watery, itchy eyes, and if exposed more often, some people develop eczema and skin irritation, and the problem with allergies, Akron has pointed out before. So the next, please. Yeah. Associated with the use of formalin, including miscarriages, neurologic diseases, including amyotrophic lateral sclerosis, ALS, and even cancer development in the long term. Next slide, please. Next slide, please. Yes. So some people might argue such little exposure levels towards formalin in GI endoscopy don't worry me. They should not really matter. I'm not exposed to much, and so on. But there is a simple mathematical way to calculate each one's formalin personal formalin for 35 years as an endoscopy assistant per times 200 work days a year, and just send 40 biopsies a day in containers to your pathologist, you will end up with a number of approximately 280,000 biopsy containers with formalin solution during your working days, which immediately should raise the question whether or not a systematic workplace measurements of formalin exposure in the air should be performed, given that high numbers of containers that, once again, release the formalin gas immediately after opening. So next. Yeah, next slide, please. And to put this in perspective and to become a little bit much more up close and personal here, the steady use of open formalin containers in endoscopy almost invariably all over the world has to be refilled by the endoscopy staff. So these are the people who gets the highest exposure levels to formalin gas in our endoscopy units. Next, please. Just hit, yeah. And we experienced over time, a couple of years ago, we know about frequent airway and skin and mucosal surface irritations in several of our workers. Next, please. Next. Yeah. Also, at the same time, we had the occurrence of breast cancer in 3 staff nurses and technicians in our unit. And I'm not saying, just to be careful, I'm not saying this is directly related to the exposure of formalin, but it happened all at the same time when the workers were complaining about their airway problems, skin irritations, and bad air quality. And at the same time, we had 3 staff workers who developed breast cancer. So this immediately called for, please. Next one, please. Yeah, so what we did first was to call for a departmental board review, and this board review decided that actions have to be taken. So the first step that we took, because nobody believed this could be in any way related to our little formalin containers, but we had the authorities to perform laboratory measurements of environmental formaldehyde gas exposure in our very bad ventilated endoscopy rooms during the summer. And as results, we found we were really, it was striking. Far too high and exceeded the number of 0.8 parts per million over 30 minutes or even longer, which was clearly above the permitted rates Akron has shown you. Even if you go to the more lenient countries, this is still a very high exposure level compared to what's allowed and what should be limited. Next slide, please. Yeah, there's also, I just want to give you a quick reminder, as shown before, the European Union has stated in January 1st, 2016, that formaldehyde was reclassified as a carcinogenic class 1B and use and management of formaldehyde in hospitals. So the EU specifically, they go even far further and state where a closed system is not technically possible, the employer shall ensure that the level of exposure of workers is reduced to as low a level as is technically possible. So here you find it written, we have to do something about limiting these exposure levels, such as those we have found in our endoscopy units. However, reality tells us, especially in Germany, that as yet almost nobody cares. So I'm not aware of many co-workers and hospitals still an ongoing matter of debate. So this slide shows you another overview about the limits per country, which we have seen before. And as you can see, the Netherlands, and which is not shown here, Japan, have the strictest values in the world, while others still have limited numbers, which our endoscopy unit repeatedly exceeded. So we had to take something, and it really worked. I tell you the clue before. Okay, next slide, please. Yes, so what could we do? How to avoid formalin pollution or formalin exposure in endoscopy suites, especially? First thing would be to insert biopsies or ESD specimens into the container under a laboratory hood, or only perform endoscopies in rooms that are equipped with laminar airflow. But to be honest, who of you has an endoscopy room at hand that offers these formalin reducing or formalin eliminating technical possibilities? We don't have this. So another possibility would be to use alternative fixation agents. There are some, yes, that's true, but they haven't come very far because most pathologists and most doctors in the endoscopy field and in the operating rooms are not aware of something that's commercially available, it's cheap and so effective like formalin. So what else could we do? Next, please. We could also use full body protection gear during endoscopies, but that's another unrealistic, a very highly unrealistic way of eliminating the exposure to formalin, because it would, it's very uncomfortable to wear this stuff all the time and big masks all around you. We have seen this during the COVID epidemic, how difficult endoscopies had become. So that's another option that's not really realistic in everyday life. So next, please. So we finally ended up with our approach, which was to immediate change the formalin containers and towards using closed container systems such as those purchased by Axlab that you will see soon after this talk. And since we started to use these closed container systems, we almost entirely, by repeated room measurements, we could show that the formalin exposure in the endoscopy almost vanished. And also the skin irritation, the number of complaints about the bad air in our endoscopy nurses almost vanished totally after a couple of weeks. So this short video shows you how easy it's to use these closed containers in practice. They are very simple, they are very handy. All you have to do is to put your specimen inside, close it, make sure it's closed, and then you press the knob, and there will be an immediate release of the 4% liquid formalin solution into the closed container. You can shake it, you can even throw it to the ground, which happens invariably in busy endoscopies, of course, but nothing will happen. There will be no spillage, there will be no problem whatsoever. So since we have introduced these containers, we virtually didn't have any more problems with this. What are the barriers towards the use of closed containers in endoscopy? There is still a tremendous lack of knowledge about potential health hazards of formaldehyde gas, which is one of the reasons we have this seminar here today. Second, the next thing is, please hit the button. Yeah, there's also a lack of knowledge about non-hazardous techniques such as these closed containers as shown before. Next, please. And there, of course, one of the most striking barriers in Germany, especially, are the cost considerations. Because if you switch to these closed containers, they will be approximately 10 times more expensive than these ultra cheap open container systems. But next, please. There's also, finally, there could be some resistance of some pathology labs, but that's the most easy part to overcome. Just talk to your pathologist what we are doing and that we're going to change. And after that, you won't face any big discussions with our colleagues there. So to eliminate these cost arguments, I've given you here some tips and tricks. First, it's the law. It's almost like the law. As I've shown you before, the EU Directive 2004/37/EC clearly states that the employers are, it's necessary for employers to reduce the exposure of workers to the lowest level ever achievable. And there, of course, in every hospital, in every practice, there are cost reduction strategies like getting rebates by large shipments or mass orders, and also to get reimbursement from self-paying patients, so which depends on your local health system. And you can add savings. We will have savings when you switch over to closed container systems because we need much less protective gear to protect us from these hazardous gases. And finally, there are indirect cost savings given the motto, save your staff from environmentally induced sickness. So each case of a preventable disease that occurs and has to be treated saves you a lot of money. Of course, it's not saved in our department, but it's saved for the hospital employer, for example. So the cost argument is not really striking. We have found ways to overcome it, and I've shown you some tricks how you could do it as well. So finally, how to improve, I will finally get you an answer, how to improve air quality at your workplace. First, assess your workplace air quality and maybe perform laboratory tests. Next, please. If everything's okay and your laboratory tests come back without high numbers of formalin gas in the air, you can proceed with your hitherto procedures, and or you can, of course, you can change to your biopsy protocol and use a dedicated hood. But that's very difficult and usually it doesn't work. But if your environmental air contains formaldehyde gases in relevant numbers, you should change your biopsy approach as shown before, as we have done successfully too. Next, please. So the easiest way, in my opinion, is that everyone gets closed containers for biopsy, EMR, ESD specimens, for every tissues we obtain in the endoscopy use. And the problem has been totally eliminated. There won't be any occupational health hazards from formalin, and everyone could be happy, except your hospital purchasing department, which can be convinced if you tell them the arguments I've shown you before. Finally, next slide. Yeah, in conclusion, itchy eyes, running nose, and other health hazards from formalin can be avoided for your staff and for the good of your staff, which is very important to keep your workforce in the hospital alive and kicking. Closed containers offer an easy, simple, and effective solution, and it's astonishing how this problem is still being ignored in several countries, but in others not. So this is why we're sitting here and we're talking about this. And finally, just to give you a little idea, that people in Germany, this is a very old ad from a German hospital released in 1916 that advertised formalin solution to gurgle it and put it in your mouth and get rid of bacteria. So the approach towards formalin has changed over the years tremendously. And why don't you go ahead and do the same like we do and get rid of the formalin stuff? Only the pathologists need it. It's good, it's cheap, it's effective, but it needs to be totally kept away from all endoscopists and endoscopy nurses and everyone who works in that environment. Thank you very much for your attention.
Thank you very much, Professor Hollerbach, for this very interesting presentation. And the final slide was really revealing on the approach, how it has changed and how it has to change still. Now I'm going to share my screen. Okay. Okay, so after these presentations from Akram and from Professor Hollerbach, formaldehyde, clearly it's a harmful substance. We should avoid the exposure whenever it's possible. And it can be implemented in any medical department, even in the endoscopy, as we just heard. Okay, let me explain you a little bit of how can we solve this problem for the healthcare workers. First of all, how we started our company. This was an idea, it was a family company, it was belonging to my uncle, and he had an idea on 2011 to avoid exposure to formaldehyde because his wife, who happened to be a lab worker, was extremely sensitive, super sensitive to formaldehyde. So he created the Biopsy. Okay, and since then, since 2014, when we got the CE mark and all the approvals, we started to sell all over the world. So you can see here, as we saw with in the video that Professor Hollerbach showed us, the product. Okay, it's a patented closed system. Okay, it's a very easy and fast to handle. That for us was very, very important. It has to be safe, which it is. It locks perfectly, and there are no leakages, which is happening today with many other vials that they have leakages. When the laboratory receives the biopsies, there is leakages in the bottom, and it's very fast and easy to handle in the medical departments. So it's just as we saw, open and close, open, place the biopsy, close, and that's it. Okay, we are the legal manufacturer and IVDR, of course, compliant. And our aim is to improve the working conditions for all of you. Okay, so that's why we are here. We know that we are very successful in some countries, and others not so much, as we saw in Professor Hollerbach's presentation. In Germany, we are not so successful, but to give you confidence, you have to know that every second a Biopsy vial is released in the world. So if this presentation is lasting 1 hour, when we will finish it, there will be 3,600 vials used. In here, you can see that we have already sold 30 million units. That was, you cannot see it. You can see it now? Okay. Thank you. So we reached this milestone of 30 million units sold. That was before summer. Now we are already in 33. So again, to give you confidence on that our product is working perfectly. You can see here in the European Union, which is our main market, our market shares and how much we sell. We have very strong success stories in Spain, in Italy, in Poland, in Denmark, Sweden, even France, and we are selling more or less over the whole European Union. We also sell in out of the European Union in Latin America. By the way, give me the chance here that we see this map to say good morning to all our American attendants. Good evening, good afternoon to the European, and good evening to the Asian participants. What we have learned throughout these years is that there are some departments that do many more biopsies than others, or if you want, that use many more vials than others. You can see here, this is the study we performed internally with a number of hospitals in Spain. After 10 years, the level, then the percentage of vials per department was, as you see, endoscopy was 43.69, which is almost half, operating theater 21, interventional radiology almost 10, together with dermatology, gynecology, urology, and others are also important. Also understanding that sometimes interventional radiology, gynecology, and urology, depending on the country and the hospital, are mixed. Okay, but here I think it's very interesting to see that despite being a transversal procedure, it is endoscopy is the most important department for number of vials. So what does that mean for you? We saw it in Professor Hollerback presentation. He did it with 40 per with 35 per day. I did it with 30 per day, but I mean, at the end, if you more or less know how many biopsies you do per day, you multiply it for 7,000, and you will have the number of biopsies you will be exposed in your life. And of course, this is again to give liability. We are QA and compliance complete product. So we have the ISO, all the ISOs needed, and we are IVDR. And this is really a product that you can buy with no problem. It has been, as you have seen, used more than 30 million times, and we have no complaints. So we invite all of you to change if you have not already changed. And now it would be the Q&A part. We're going to see what questions. I think there is a question for Akram. So it says, can formalin be harmful to an unborn child? Akram, you can.
Hi. Yeah, that's a really good question. Well, the reality is that research has been done in lactating animals and suggests the formalin levels are higher than 2 parts per million can enter animals' milk. But we haven't done this for humans. And current exposure limits were written for healthy non-pregnant workers and might not protect the, these limits might not protect the developing fetus because we don't know. So so I guess the answer is that there is no scientific evidence that it would affect the unborn child, but it doesn't mean that it doesn't affect the unborn child. It just hasn't been human serious human research, so we can see, if an unborn child is affected. All the research has been done in healthy non-pregnant workers. But with that being said, I mean, prevention is always the key. And if you can minimize, like I said, and like we said, the exposure, you don't have to be the one who finds out if your unborn child is affected or not. So I would say stay away from it. Even more if you're pregnant, because like I said in my presentations, because it's two patients. It's the worker and the fetus. So yeah, sorry, I don't have a more concrete answer, but I have to go by the scientific evidence. I would say stay away from it, and even more if you're pregnant.
Yeah, thank you, Akram. Clearly, what your answer is that it has to be avoided whenever it's possible, basically. Okay.
Yeah, absolutely.
Another question is, what happens if the workplace do not follow the regulation and guidelines for exposure to formalin? What can they do?
Well, I would say, there are laws and regulations per country, and then, and every law and regulation for occupational health and safety in the world has consequences. If you don't comply with your country's regulations, there are different consequences to different parts of the world. You can get an inspection, you can get some sort of a monetary summon, you can close down a lab. I mean, it differs depending on the country. But more than the regulatory part, I think having an open and honest discussion with the employer and the workers and the scientific community, to understand, what are the implications, and why should we prevent the exposure. It's the best way to go, and not be so imposing regulatory issues, but more having an open participatory discussion towards that. I mean, that's my recommendation. And this goes beyond formaldehyde. This is for every occupational exposure.
Okay, thank you very much, Akran. We have another question for Professor Hollerbach. And the question is, what do you need if you have to do it with protecting gear? What would be the protecting gear you were mentioning? I'm afraid we cannot hear you.
So this is a question more for Professor, but I can take a shot.
Yeah.
Yeah, I'm not an expert in PPEs, but like I mentioned on the prevention through design, you want to eliminate or minimize. But if you remember the inverted pyramid, we can also combine, and then you can use PPEs plus the elimination or minimizing the exposure. So you can do engineering control. So you can do combinations of preventive measures. But if you eliminate, the lower you go into the pyramid, the less you need, because you've done the very best.
Of course.
So you want to save. Ultimately, if you do the very best, then you save money on the others, because you don't need to do engineering controls. You don't need to wear PPEs, because you've already done the best prevention possible. Now, some workplaces do combinations regardless. There's Stefan. I mean, I don't know if you want to add something, Stefan. That's my point.
I'm sorry, I lost the connection. So what was the question again?
It's what is the protective gear that they need to use in case they don't?
Yeah, that's FFP, dedicated FFP3 masks. So these dedicated masks we have to wear whenever there's an exposure to gaseous substances. There are these dedicated, very expensive.
The ones with the two exits, right?
Yeah, exactly. So it depends on the local country's regulation, but usually that's the stuff we are using here in Germany and in Europe.
Thank you.
These are very expensive, very uncomfortable. You wouldn't wear this for 2 or 3 endoscopies in a row. That's virtually impossible.
I think, as you said, I can say from my experience, when there is a formaldehyde spillage, then the kind of mask is not a PP2 or PP3. It's this very big and heavy one. It's nothing comfortable.
Yeah. Now you're right. Even the FFP3 doesn't shield you. That's an important comment somebody just made. Even the FFP3 mask doesn't entirely eliminate the problem. So probably you would need to wear a gas mask or something. So I just pointed this out because nobody's using it. It's virtually impossible to get help by protective gear under such circumstances.
Thank you. And now there is a question that is for you and for me, for both, but I will place it. It says, is it possible to add saline to the vials? This makes it easier to get the samples in the vials instead of an empty vial. Let me start, and then I let you the word. Yeah, some endoscopy departments say that it's very hard to leave these very sticky and small biopsies in an empty vial. I would like to ask you, Professor Hollerberg, how you do it in your hospital?
Yeah, that's very simple. That's very easy to answer. What we do is we pour in about 1 to 2 ml of saline solution, 0.9% saline solution, and that makes it, that usually facilitates to scrub off these little biopsy specimens from your biopsy forceps or from your US needle. And in some cases, it's useful. You can also use the plastic grid underneath the cap, as Ferran just shows you. You're right. So can you see this little grid? And all you have to do is to pull your biopsy forces carefully over the grid, and you get rid of the biopsy and put it in the vial and press the button, and you're all set.
Yeah, thank you very much. Very good. Yeah, sometimes, as Professor Hollerberg said, 2 ml in a 20 ml, there is no problem. We have tested that is not a problem on the fixation quality on that dilution. And there is also the grid. Some others use a needle to remove the, but
Yeah.
In this case, there are different procedures, but it's not a problem.
Yeah, that's another option to just take another second needle and to scrub it carefully, scrub it off your biopsy forceps out of the claws.
Yeah, clearly. So, are there more questions? It seems so. Okay, how to protect during fixation of larger samples? Okay, that would be for me. As you know, we have these 20 ml and 60 ml vials. Here you can see both. In the most conservative ratio from pathology lab, we say that is 20 to 1. The relationship between the amount of formaldehyde and the volume of the biopsy is 20 to 1. Many labs say 10 to 1. We went to the most conservative, which is 20 to 1. This allows to put biopsies up to 1 cubic centimeter here in the 20 ml and 3 cubic centimeters here in the 60 ml. For bigger biopsies, our recommendation is to use machinery. There are machines that are weighing the sample in vacuum, placing the proper the formaldehyde capacity that this biopsy need, and this can seal the operation room totally free of formaldehyde.
Camera on and off.
It says, I am a nurse and I am concerned with being exposed to formalin. Who in the hospital should I reach out regarding this matter?
Can you repeat that question? He said, I am a nurse. I think the presentation froze. Okay. I think I heard, can you hear me? I can answer that. Okay. Okay, we hear you. Yeah. So there should be an occupational health and safety department, and technically in every hospital or every workplace. So you should reach out to your occupational health and safety department to do the proper measurements and implement preventive measures. There's also employee health service, what they call, which is where you go when you do your pre-employment testing when you first start working. You can also go there. And if there is none of those, I would if there's no occupational health and safety or employee health service, which is a small workplace or something like that.
Here we are again. Sorry for that.
I would.
There was a question for
I was answering.
It said,
I was answering that.
I am a nurse and I am concerned with being exposed to formalin. Who in the hospital should I reach out regarding this matter?
Yeah, I was answering the question right now. And if not, I would support yourself with human resources. But technically, it's the occupational health and safety.
Akram, we cannot hear you.
Rest scan.
Okay.
Rest scan.
They say they're hearing me in the chat. Yeah, we can hear Akram. So he says, okay. Yeah, I already answered the question. Did you hear my answer, Stefan? You can add something, okay?
Yeah, I think it's a similar question as before. Yeah, you're right.
I'm sorry, I lost the connection again. What was the question before?
She said that I'm a nurse and who should she reach out in the hospital? And my answer was, you should reach out to your occupational health and safety department if there's one. If there is none, you should look for an occupational physician. There should be an employee health service. When you first start working, they do a pre-employment testing. You can also look at that department. And if it's a small workplace that you have none of those, I would support myself with human resources. That's the last resource.
On the cut,
But human resources is not an expert on it. You eventually have to get an expert on the area. So.
Exactly, that's exactly the train I would follow. So in our hospital, we have a security or safety officer in working in the department. Also, there's a safety physician who takes care of the employees, of the health problems and the health issues of the employers. If this doesn't work, you can still send a question out to the local authorities, which in Germany are usually those authorities responsible for surveying and supervising hospitals and medical places. But that may differ between different European and other countries. So that's usually this can be seen on the hospital homepage. Whom to contact first. But I would recommend that the entire department gets together and calls to see who is capable of carrying this information further.
Thank you very much, Professor Hollerbach. There is a last question. This one will be for me. Would there be difficulty delivering to Northern Ireland due to Brexit? Okay, well, we have a distributor in Ireland called IHS. They are very professional, and I know they are already delivering to Northern Ireland, so I'm pretty sure there will not be any problem to deliver there. So I think with this question, we are finishing. Sorry for the technical issues we have had at a certain stage, but I think we have succeeded giving you the message we wanted to give. I thank you very much, our speakers, Professor Hollerbach and Akram, and I invite you to think about your exposure to formaldehyde and try to avoid it. Okay, thank you very much.
Thank you.